Thank you for joining us this morning. Welcome to SPIA Annual Session 2021. We have with us Dr. Teresa Gonzalez this morning. After nearly 30 years of distinguished service, Teresa Gonzalez retired from the United States Army in 2013 with the rank of colonel. In her last military assignment, she was the nominative selection as the Director of Strategic Communications for the Army Surgeon General. She has commanded formations in Europe and the United States. Prior to her successive command selections, she served as the Director of Orofacial Pain Management and a staff oral and maxillofacial pathologist at Tripler Army Medical Center in Honolulu, Hawaii, and Walter Reed Army Medical Center. Dr. Gonzalez graduated with the distinction from the College of Charleston, and she received her DMD from the Medical University of South Carolina. She began her military career at Fort Jackson, South Carolina, as a resident in the Advanced Education and the General Dentistry program. She completed a residency training program in oral and maxillofacial pathology in 1992 at the National Naval Medical Center in Bethesda. In 2006, she completed a 2-year fellowship in orofacial pain at the Naval Postgraduate Dental School and completed a Master of Science in Healthcare from George Washington University. Dr. Teresa Gonzalez has published more than 75 articles in peer-reviewed journals, and she presented more than 1,000 hours of continuing education lectures, both nationally and internationally. Presently, she serves as the Executive Director of the American College of Dentists. Dr. Gonzalez, thank you so much for joining us this morning.
Thank you very kindly.
And our other speaker is Dr. Leo Rouse. Dr. Rouse serves as president of the American College of Dentists and as ADIA consultant and ombudsman. He's a former senior scholar in residence at the American Dental Education Association, past chair of the ADIA-G's Foundation Advisory Committee, and former liaison to the ADIA Council of Deans. He is professor and dean emeritus of Howard University College of Dentistry. Dr. Rouse, as a representative of ADIA, served on the expert panel of Interprofessional Education Collaborative that was charged with developing the core competencies for IPAC. He has served as a member of the National Advisory Committee for the National Center for Interprofessional Practice and Education. In March 2010, Dr. Rouse was elected President-elect of ADIA and was installed as the first African-American president of ADIA in March 2011. 3 pertinent awards that he has received from ADIA include the 2017 ADIA Distinguished Service Award, the 2009 ADIA Presidential Citation, and the 2015 and 2019 ADIA Chairman of the Board Citation. He is the recipient of the American Dental Association 2020 Distinguished Service Award. Other recognitions include the 2015 Alan J. Davis Student Clinician American Dental Association Achievement Award, the 1997 Howard University College of Dentistry Alumni Achievement Award, the 2011 Sterling V. Mead Award from the District of Columbia Dental Society, and the 2011 Legend Award from the National Dental Association. Upon his retirement as Dean of Howard University College of Dentistry, he received the 2015 Trailblazer Award from the National Dental Association and a 2015 Presidential Citation from the American Dental Association. Dr. Rouse was awarded a Doctor of Humane Letters honorary degree from the Western University of Health Sciences in May 2014. He served for almost 30 years in the United States Army Dental Corps, retired in 1997 with the rank of colonel. Final assignment, Commander, United States Army Dental Command. Thank you for joining us, Dr. Rouse.
You're very welcome, Matt. It's my personal privilege. Thank you.
My name is Timothy Nye. I'm a 4th-year dental student at Indiana University.
My name is Ans Kadri, and I'm a 4th-year dental student at Boston University.
And my name is Rebecca Long. I'm currently a D4 at USC Dental School, and I will be your moderator today. In today's session, we would like to discuss health inequities and inequalities. This discussion will be focused on what are health inequalities and inequities and how do they affect our population. Enjoy.
Dr. Rouse, thank you so much for joining us this morning. Again, this discussion is over oral health inequalities and inequities. Again, these are very new terms for most dental students and myself included. Would you go over exactly what an oral health inequity and inequality is, how it's played out in your career, and how it's impacted the profession of dentistry?
Yeah, thank you for the question, Tim. And I always start out the conversation in reference to oral health inequality and inequity with a story about a young 7-year-old, a young 12-year-old rather, named by the name of Diamante Driver. You may not know Diamante. On February the 7th, 2007, experienced an acute episode with a abscessed tooth. And literally, he had gone to a clinician in the county where I live, in Maryland, and was denied access to care because it was not Medicaid eligible. That created a whole lot of conversation in reference to what do we do as clinicians when it comes to acute episodes. And the key thing here that I like to stress, regardless of who the practitioner may have been, the reality is he needed to basically be seen. Now, tell the whole story. This young man had a lesion, carious lesion, went up in the Children's National Medical Center in Washington, D.C. An $80 procedure resulted in an over a couple of $1,000 procedure for brain abscess, from which he died. As the story is told, you may remember Congressman Elijah Cummings from Maryland. He passed away several years ago. As a dean, I got a call from Congressman Cummings, who was also a Howard alum, and he said, "Dean, what are you teaching your students about providing healthcare to those who come through the door?" And this is a young African-American man, young boy rather. I know his mom very well, Mrs. Driver. I had a long discussion with Congressman Cummings. And the point I'm making is, regardless of who is able to pay, lack of insurance, Medicaid ineligible, we are responsible for providing healthcare. And that has stuck with me since 2007. Now, let's go back. 7 years before that, Dr. David Satcher, a former Surgeon General of the US, published the first ever document on America's oral health. And in that document, they concluded that caries is the #1 issue or the #1 disease of children. Now, if you know David Satcher, as I know him personally, former Surgeon General, he is big into health inequality, inequity of healthcare, et cetera. And I will tell you, that has resonated with me since 2007. And so when I talk to young men and women, and I'm really proud to be looking to the SPEAR group because it's important to know the history of what goes on. And, you know, we sometimes forget what our responsibilities are. And that's just an example. That's one example. There are many more examples of that. But that one is highlighted because that particular situation led our Congress and the state of Maryland to establish the SCHIP program and the CHIP program to ensure that young folks have access to oral health care. And so I'll end with that, but you know, I'll yield to my colleague, Dr. G, because she's my resident oral maxillofacial pathologist, and she's been around for a while, understands the big picture. But I say that to the group and to all those who are listening to this podcast. Understand that the humanistic thing to do is to access care to all individuals. And we'll get into the Medicare discussion a little later, but that's my point about that, Tim. Good example.
Thank you. And Dr. Gonzalez?
Thank you, Tim. And thank you to the organizers of this conference, because the discussions we'll be having today are the challenges of our time. and made more prevalent and evident, even among those reluctant to do so, by the pandemic and the scenes that could be exploited in terms of inequality in access to care in general, not only dental care. So a couple of things. If health equity, which I think is a destination, and on that journey to health and equity is where we encounter inequality. But health equity is nothing more than the ability, the opportunity to be as healthy as you can be, as healthy as you can be. We identify in the context of equity populations at risk, and those populations at risk are where inequality meets equity, where there is not access either administratively or financially or societally to provide care for those most vulnerable members of our society. And to Dr. Rouse's point, they tend to occur on each end of the age spectrum, of the very young and the very old, and then many in between. But those are the most disproportionately affected by inequality in our destination or on our journey to equity. So that's important. The other issue I'd like to have, and I'll try to refrain from this too much, because the problem with both Colonel Rouse and Colonel Gonzales is we have worked in organizations that had equity front and center. The expectation in military health is you are fit and ready force for deployment to engage those threats to the United States at home and abroad. That is part of our mission. And to do that, you have to be healthy. So we invest in wellness and equity. And then we make as conditions of employment the opportunity to keep you fit to the extent we can and well. Well is different from being just the absence of disease, unwell. So I want to talk about equity in that sense as a societal determinant and in military service and a condition of employment. So when that exists, we acknowledge a couple of things. Most of health care does not occur in those short minutes where we actually engage a primary care physician or a nurse practitioner or a PA or a primary care dentist, but rather in the general behaviors we have. On that, I'm going to borrow a line now from the Broadway musical Rent. In that 525,600 minutes, about 100 minutes a year are given to healthcare. You're not going to have health equity in 100 minutes a year, even if you had full access. Health is what occurs outside that. And crucial to that would be sleep and wellness and education. Dr. Rouse and I have had the privilege of working in systems that mandate equity. And I mean mandated in terms of you must be fit to fight as a military acronym. The other is everyone in military service through as a benefit of employment has access to those resources to allow it. So here you have equity and equality, and you have it undergirded by the missions of the myriad missions of the military that insist upon it, that wellness is our destination. In theater, out of combat theater, at home and abroad. So that's important. So I think that when I separate equity and equality in my mind, equity is the opportunity, equality is the administrative burdens that either allow or disallow the opportunity to engage. And I'll end with that discussion with a military over to let you know I'm through transmitting.
Ants, would you like to follow up?
Yes. I really liked what you said there, Dr. Gonzalez, about how there's just the 100 minutes that we devote to our health, but what really determines our health is what we do outside of those 100 minutes and how we take care of our bodies. And an issue that I have been learning about recently is access to nutritious food or even supplies to use for oral hygiene. And something I've been thinking about recently is there's these things called food deserts all over our country. And there's private entities that are making it part of their mission to reduce food deserts, companies like Unilever. And I'm wondering if we as clinicians should start pairing up with some of these companies that are making these initiatives and start working with the private sector to incorporate oral health into some of these initiatives and use the resources to the maximum efficiency we can. And if this is something you guys have heard about in your life or some of the meetings you've been to.
Well, Ance, you've directed that question to me, so I'll start. I grew up in a food desert in the rural Southeast. And so, first of all, absolutely, food deserts exist. And it is important, remember, in that 525,500 minutes outside the normal healthcare continuum, that's where health happens. That's where health happens. And crucial to that are these social determinants of health. Now, for a long time in small communities like mine, independent grocers, I always tease and say organic food is what our parents used to call food, because quite frankly, everything was farm to table, right? And small communities were farm to table. So produce kind of depended on the seasonal variation of what was essentially being harvested. So we had access to that because this was a rural area. But in time, these small IGA, independent grocery stores, gave way to larger deliverables, but that were geographically more remote, right? And that becomes a problem in terms of getting there. And then bulk replaced, quantity replaced quality as part of the American diet. And it's expensive to eat healthy. You know that. I live in Washington, D.C., and you know that it is not cheap to do so. And to their part, and I don't want this to look like I'm maligning, but many small venues came in to sort of help with the food desert concept and deliver food, but again, more of a quantity, not quality. But again, in a food desert, that's also important. So what we have to look at is what is the distribution system in our culture? We know how much, and I'm going to speak now to the American Midwest. Tim is at school in Indiana. So you know that much of the agricultural products in our country are essentially repurposed or wasted if they are not sold, and they're done that way because that's what they have a limited time span. And the question becomes, it is not a production of food issue, it is a distribution of food issue. And to Ance's point, nutrition is crucial. If the health of all of us depends on the health of each of us, then our very first approach would be looking at where these food deserts exist, and think of them in the way we managed potable water or having water that was available for use. We need only think of Flint, Michigan, to think about what happens when the infrastructure does not deliver upon a sort of an expectation of the public. And then we set upon a course of looking at that, essentially opening that wound and saying, okay, these are things that cannot be. So food and water availability, we know that at home, we know that abroad. And secondly, social determinants of health begin and end with those healthy eating habits that may have an effect on reducing another epidemic in our culture, which is childhood obesity. Let me stop there. I hope I've answered your question.
Yes, that was wonderful. Thank you, Dr. Gonzalez. Dr. Rouse, would you like to add to that?
So let me just say, because, Teresa always, she's my partner in crime, I should say that, okay? One of the things that I'm impressed with, Aunts, and with you also, Tim and Becker, is I'm sensing that you're going beyond the call of duty, just besides worrying about drilling and filling. You're now venturing to the world of healthcare. And that's where I get excited about interprofessional, collaborative, et cetera. Nutritionist, dietitian. I think about Chef Andreas, what he's doing around the world, okay? And so this is part of the process of becoming a healthcare provider that goes beyond putting an implant in number 27, okay? And I say that wholeheartedly because I'm very concerned about the academic and the knowledge that our students graduate from school. It's just not about teeth. Oral health, there's a critical component of nutrition value. And so to hear about your concern, what you've been doing at BU and Tim at Indiana and Becker at USC, it makes me feel great because I feel you're in the classroom learning about more stuff than just how to stick an implant in a socket. As Becca knows, I tend to bring it home a lot of times. I'm very concerned about how we educate our future clinicians. Being a former dean, I get very excited. I get emotional sometimes about the knowledge base. And there those. So having gone through the pandemic over the last 18, 20 some odd months, and piggybacking on Dr. Gonzalez's comments, you guys are on point. And I hope your listeners recognize this concept of IPE goes beyond just dealing with dentistry.
I was talking to a craniofacial orthodontist. I might have butchered her title. I believe it's craniofacial. And she told me how if you get to a cleft palate or a cleft lip patient and start treatment at the proper time before they start making any humming noises or anything, you can correct the issue and the patient or the child will face less speaking issues in the future. And there have been scientific articles documenting how that patient will have a higher IQ than maybe someone who did not have early access to care. And it got me thinking how something that happens as soon as a child is born and maybe is not diagnosed or not emphasized properly with the family can have such lasting effects to the child over their life. And access to care is such an issue that we're all facing. And I think if we hear stories like that, where that emphasizes the importance of it and how long of an impact it can, maybe more of us will do something about it. But my question to you guys is, what can we do to increase access to care as students, as dentists, as pre-dental students? What can each one of us do to help increase access to care? And if you guys have any solutions to that problem.
So I'll take a stab at that. In fact, it's an area that I'm most interested in, Ants and Tim and Becker. One of the key things that I encourage folks to do is participate in community forums, community health fairs. There's a plethora cohort of men and women out there who really are not ignorant. They just don't have the literacy rate in healthcare that we understand, right? At the same time, develop relationships with the healthcare family. And that includes everyone, nurse practitioners, physicians, particularly pediatricians in the case of this cleft palate situation, and oral maxillofacial surgeons and ENT specialists. So we can go with the whole gamut. Participate in MOMS program, Mission of Mercy. You'll be surprised what you see in a MOMS program. Community health fairs. I used to despise the term an oral health fair. I changed it when I was dean. It's a community health fair to the students. And it's important that you combine your expertise and knowledge with other students who are in the healthcare family. Or when you're out of school, you get involved with the clinicians who have a common interest in what you're doing. I get very excited about the programs in Europe and Boston. You're familiar with the primary care health program and the integration of healthcare at the Harvard School of Dental Medicine. You're very familiar with that. Those programs excite me because it gives us a chance to provide our expertise with others. Community involvement is so important. When I was in school, we were taught the 5 fingers of dentistry, 5 fingers, I call it the 5 fingers of healthcare. And 2 of those fingers involve civic engagement, not to be a politician, but political involvement. How do we legislate things in healthcare delivery with the local community, whether it's the city council, whether it's the state legislative body, and the federal government? So advocacy is another point that you need to understand how to become an advocate for quality healthcare. And so I'll leave it at that. And Teresa, your comments are appreciated.
Well, thank you, Dr. Rouse, and thank you for the question, Ants. I want to go back to your original setup for the question, where you had spoken with a specialist about early diagnosis and outcomes and the effect on that individual. And I think this is true, and I think it would be universally true across primary care and pediatrics and beyond. But we do know that in general, early diagnosis applied to evidence-based therapy portends the best prognosis. That's true across healthcare domains. That's common to 68,000 ICD-9 codes. So that's all true. The other issue I thought was more compelling, and it was nuanced, and I'm glad there's not a right or wrong answer. You talked about the effect it might have on the individual who'd had issues and difficulty perhaps speaking. And it's a funny thing in our culture because we tend to sort of view people with any disability or any perceived disability to be somehow or another less capable of performing. And that's called the bigotry of low expectation. So I am adamantly against that. So the idea is, and to the orthodontist and the pediatric and this entire community, all of us who are engaged in the care and the maturation of children to their collective best, then we have to understand that those things do affect how they believe about their own ability. Now, we're lucky enough among the top 3 or 4% of people to serve as providers of oral health care. That's important. And the reason that's important is that we were encouraged along the way with people who saw our capacity, and that took hold within us, and then we tried to deliver on that promise along the way. And if we made it through organic chemistry, then in all probability, we would then make it through dental school. That was kind of our predicate. So that's important. And that's what the point I think that the orthodontist was making. It's very important to allow people, this is part of, remember, equity doesn't just occur with health, it occurs with potential. That's potential equity. You have the potential to do anything, and all you have to do is believe in it and be encouraged along the way. Sadly, though, Ants, the converse is also true. The converse is also true, that if you are not encouraged, you might still survive because if you want to learn, no one can stop you. And if you don't want to learn, nobody can make you. We know that. Mm-hmm. But the reality is, I think that's important. And that's very crucial in those early appointments with children, particularly if there's something that is socially as ostracizing as a speech impediment. So that's important. Now, back to access, which is where the question was teed up to lead. I agree. Access is hugely important to us. And one of the things that the Missions of Mercy and the Dental Access Days concepts do, that's a separate discussion on the environment of care, but what they are designed to show, and I think they do this better, is they reflect the enormity of the need. So if nothing else, wading into your community, around people you know in your community, and realizing that this is essentially, while everyone cannot be seen, you get an idea of how important it is at these sort of health fairs. That's important. But that by itself is not enough. Dentists in general are among the most generous of individuals with donated dental services. So a little shout out to that group. Donated dental services, where you bring someone into your practice and provide care as part of a continuum of care for those who are very vulnerable. So a shout out to that. The other are those individuals who look at safety net populations, those most vulnerable populations, and how we can provide care to them. As Dr. Rouse says, caries is the most prevalent non-communicable disease on the planet. So what is true in this country is true around the globe, and getting it recognized as a non-communicable disease and in that category for action through the World Health Assembly is also important. So those things are important. And then finally, and Dr. Rouse hit this beautifully, it's not enough to recognize the need and to have it generate all the requisite anxiety of unmet need. What is important is to wade in and advocate aggressively for access. Access is generally attributed for things like pain and pain management, but pain is already a disease, a prevention that failed, right? When we get to essentially an acute pain management, not so much for chronic, but for acute. That's hugely important too. So the advocacy combined with the access, combined with philanthropic goodwill through donated dental services, and then periodically taking a pulse on the community in which you reside and practice in terms of what those needs are, that will change your life in a way that enables your better angel, from my perspective, and humanitarian sort of approach to environment of care among the vulnerable. Over.
Thank you so much for both of you. I do have another question about, most of us as students came in to clinic right after this pandemic had been in full swing. And I know myself, when I was going through my perio exams, I don't think I saw a single case of clinical gingival health for about 3 months. It was all gingivitis or periodontitis because of lack of cleanings. How have you guys seen the pandemic affect these inequities and inequalities? Because most of the people I was seeing were people that had dental care before. We're talking about people that didn't have dental care from the get-go, and then only had an increase of lack of dental care due to the pandemic. How have you seen how that's affected these issues? Dr. Rouse, I'll let you begin.
Okay, so good question, Tim. You know, the pandemic has taught us all a lot in reference to healthcare, particularly when it comes to access. And you bring up a very good point. Individuals who went through the pandemic, we sort of shut down initially and provided only emergent care initially. Someone forgot to pull the switch that says we are also essential clinicians, and that was done after the fact, okay? So now we're hurry up and get caught up. There are still individuals in our communities, whether they're underserved communities, whether they're reservations for Native Americans, whether they're just high-end society communities where people were actually afraid to go out to get their oral health care treated, okay? So in my view, and I think it's something for you two and you three to keep in mind as you come out of dental school, is how do you ensure that folks do have access to care? Now, it's an individual responsibility. So I'll give you a personal example. My wife the other day just said to me, she said, we haven't been to our clinician, our personal dentist, for about 14 months. And I said, okay. I said, well, you know, we're home doing our thing. We understand prevention. We understand how to floss and brush and rinse and all that good stuff. He says, but I want to get my teeth clean. I said, well, we can call Dr. Lipscomb and we'll get it done. No problem. But that's the two of us who've been together for a long time, and we understand the reality of getting optimal health care. But we kind of miss being there every 6 months or every 12 months for our treatment. So that's my point, Tim. It's about how people are educated to know the reality of lack of good dental care. And regardless of where you're from, you have to make it known.
No, thank you so much. And you can call it a rabbit chase, but I mean, I think it goes back to the fact that this issue is bigger than just one area of concern. And I really appreciate how you've gone back to IPE so many times, because I think that's huge for this issue. So I really appreciate that example very much. Dr. Gonzalez, go ahead, Dr. Rouse.
I thank you for your comment on that, because I'm passionate about that. I am very passionate. Sometimes my wife says you're just maniacal about IPE.
So I just wanted to bring up that IPE really is the success to lowering health inequities and inequalities. Without discussing full systemic health, how are we ever going to convince a patient why oral health care is important? Why do you have to brush your teeth? Why do you have to keep your teeth? How does talking affect the psychological component, speech, all of that? All of these things are so incorporated into full systemic health. So many aspects of health inequities and inequalities happen in overall healthcare. It's not just oral healthcare. Of course, they're present in oral healthcare. That doesn't mean that we stop there. There's so many ways that we see the interconnection between systemic health and oral health. And this is how we can create that trust between our patients and our skill set. You know, they go to the physician and the physician tells them one thing, and then they go to the dentist and they say the other thing, and it's never quite in line. But we can do that with IPE. We can learn, the doctor can learn, well, you know, yeah, you're having GI problems. How have your teeth been doing? Have you been eating well? Oh, you have pain in your mouth? Have you gone to see your dentist recently? Why are we not making that more of a cohesive system, being and treating actual comprehensive care, not just comprehensive oral care, but comprehensive systemic care?
Okay. Well said, Becker. Yeah. Well said. Well, I got to tell you, as your point is well made, Becker, this is about health care. And as long as we understand the reality of all the men and women involved in healthcare, including the veterinarians, because veterinarians are critical. Pets are critical to optimal healthcare. We know that from science, okay? And literally, so enough said, but IPE, as you know, I'm a proponent until hell goes, whatever. I'm going to still be on the front lines fighting for IPE.
Thank you so much, Dr. Rouse. We really appreciate that. Dr. Gonzalez, would you like to respond to that as well?
Yeah, so I'll take us back a little bit because the conversation has been it has been very enlightening and very appreciated. But I want to go back a little bit to the pandemic specific aspect of it. So in times of economic excess, healthcare inequities still exist and inequalities still exist, but they're seams, and they're seams that can be exploited, but they're seams. In times of economic hardship, there are gaps. And in times of pandemic, they are chasms. It's very important what happens during this time. Now, the reason that happens, there are a couple of reasons. There's been a lot written about this, and all of it has been very enlightening, but it's been written from different perspectives. So you mentioned earlier, Tim, about the sheer volume of periodontal involvement you saw in that rotation in the pandemic era, pre-vaccination era, we'll call it, the pre-vaccine era. So a couple things happened. Dr. Rouse talked about them. Two things happened as a priority. Once there was less availability of the provider cohort during the most critical time in the initial shutdown. That would have been about March of 2020. And then there was patient hesitancy. And that patient hesitancy was that all elective sort of considerations they were going to defer. That allowed the resources to be used to manage the first wave or the second wave of the pandemic, and also those things which were necessary but not critical could be deferred. So deferred care. So this enormous burden of deferred care that existed. So that may have, when we did open back up, that may have accounted for the frequency. The other is a sort of a nature issue, which has been written about by people who are in psychology and psychiatry and behavioral health community and social work. And that is when challenged so aggressively by a pathogen of the magnitude that we had not seen really since 1970, right? The so-called Spanish flu. The enormity of what was transpiring led to a couple of human behaviors that are not particularly health behaviors. One was most people gained a little weight because every meal was their last one, right? So everyone got a COVID supplement, I called it, in terms of their weight. The other was people who drank typically could have their wine delivered and would often drink more because they had more time to kind of reflect on it. So there's a lot of comfort and self-soothing that goes on when each individual and each family and each community is under crisis. And those are stress behaviors, and chemical coping with alcohol is a stress behavior, acknowledged. And then finally, we sort of attenuated that aspect by going back outdoors. And what began as an environmental movement of Earth Day in 1970 sort of reacquainted us with the outdoors because we could meet the public health requirements of socially distancing, being outdoors, and not transmitting disease. So that sort of reacquainted an old love affair with nature. So that was part of that discussion. Now back to the treatment aspect of it. So behaviors changed, behaviors defaulted to comfort approaches, which is typical in crisis. And then it's true of the Second World War, it was true of the AIDS crisis. It's always true of populations under stress, right? The other issue is back to IPE, and that's why I think that conversation was perfectly timed. So now we have this burden of disease, and I mean just frequency of disease, not a true burden, but these individuals that we must manage airways and beyond. And we must treat them with available resources. And you begin to see location after location, state after state, who are having to sort of walk back volitional care or elective care to manage now the enormity of burden of now the Delta variant wave of COVID. So that's sort of where we are in that concept. It's so important in the continuum of care The continuum of care requires that each member not provide their level of care and surveillance. We all screen for COVID and refer and manage those patients as part of the infectious disease response of the healthcare community in this culture and on this planet. We all have to do that. The other issue is, I think it's important, and I heard Becca say this, and I've heard Dr. Rouse say it on numerous occasions. These sorts of so-called hierarchies that exist in the continuum of healthcare are really created hierarchies, right? We're all primary care something. We all do primary care. Where the touch point we deliver it is what varies, right? But we're all primary care providers. And as primary care clinicians and providers, we have a primary care responsibility, and that is the public health and the public good. How they enter is really, if you come to the emergency room and you get admitted, you still are an emergency room retrieval. So that's important to remember. By flattening the hierarchies, we do more than make it a continuum of care and use the resources far more wisely than historically we have done. The other thing is we enhance patient safety, because we all feel as valued members of the healthcare team, we are going to report, we're going to refer, we're going to make these transfers from point of care to point of care more seamless. And so IPE and IPEC here is flattening those hierarchies, patient-centered, patient-safe, universal screening at all of our touch points of care, and then distributing that care in the triage system in a public health crisis for those who need it most, because we're still going to have cardiac arrest, we're still going to have strokes, and we're going to have them in the COVID world. And so for those reasons, this priority is not a rationing of care, it's a distribution of care so that the most affected and the highest risk for asystole are managed first. That's an emergency room mandate anyway. So I think all of these are interconnected, and that's why the conversation sometimes gets sort of woven like a tapestry. And I think that's probably appropriate. Over.
Thank you both so much for the reminders of how we are first primary care physicians, and we, like you said earlier, we own dentistry, but we do not own oral health care. I think that's great for us all to keep in mind while we're treating patients.
So I do want to start rolling into the Medicare, Medicaid debate, and just kind of I want to pitch what those are. As students, of course, we work with a lot of patients who are Medicare and Medicaid, and I just wanted to differentiate between the two just to give a little bit of background knowledge. So Medicaid is based on income level and is care given for oral health benefits. It covers the basic needs such as like a cleaning, fillings, extractions, things like that. Benefits do vary state to state. They are financially supported by state. So it's not a federal thing, it's a state thing. So it can vary state to state. I know Ans was talking about in New York, they have some different benefits than I see here with my patients in California. Now, Medicare is based on age. Once you turn 65, you are placed on Medicare. It is a federally funded health insurance, but it does not include oral health care. So unless you have supplemental insurance at the age of 65, you will no longer be receiving dental coverage. And unfortunately, 65 is really when we see a lot of oral health changes. You know, we see xerostomia, we typically see more decay at this point. This is when teeth have kind of lived out at 65 years of life, well, about 55 understandably, because you have to exfoliate your primary teeth. But these teeth have aged and they have had distress on them and they've lived a life. And what's unfortunate about the Medicare program is that when you really need oral health care the most, it's not there. And so we want to get into that discussion of why is it not there? How could it possibly be there? And what are the challenges that we're seeing to bring that to the Medicare system? So Ans, please feel free to introduce this a little bit more and bring up the discussion and let's talk.
So I think right now is a great time to be talking about this because what's going through our government and Congress right now. And we met earlier this week and talked about why we believe the ADA is against including dental benefits in Medicare. and we brainstormed and we tried to play devil's advocate and go for both sides. But what we really wanted to do was ask you, Dr. Rouse, and you, Dr. Gonzalez, why you think the ADA stands against it, and what, I guess in the grand scheme of things, because we don't have a lot of real world experience to understand these things, and maybe why they're against it and what their possible alternative is, and help us students understand their stance on the issue a little bit more.
You know, I've been an ADA member since 1969 when I started dental school. And I'm an ADA card holder. And I will tell you, part of the problem is, and it's two things here that I wanted to share with you real quick, and then I'll let Teresa jump in, because for me, it's very personal. You all aware of the Santa Fe group?
No, sir.
All right, so Santa Fe group is a group that was founded by Dean Emeritus Mike Alfano. Oh God, beginning around 2008, 9, 10, literally talking about this subject of oral health, dental benefits, hearing, and sight for those who are Medicare eligible. Back to your point, Becca, earlier, Medicaid is basically state run. So that's dentists in the state, and the state determines the actual reimbursement rates, et cetera. Medicare right now is a hot item because we have not prepared ourselves to eliminate CDT codes, migrate to RVUs, which is a medical billing system. We have not decided on what kind of computer system we're going to use, technology, to lock into the other healthcare world, i.e. IPE, okay? And it's just basically because we have not allowed ourselves to accept the reality of being one healthcare family. I have been pro RVUs for a long time. CDT codes. Teresa's worked in hospitals for her career. And, you know, we're having this conversation about why do we not want to support individuals 65 years of age and older to have access to healthcare, those who are not able to get prosthetics, and those who are not able to get those things that sustain quality of life. Medicare Part B, they claim, is only for physicians. We can be part of Medicare Part B. We just change a few things. So what we have to do is change a few things. The technology, our coding system. So are we being managed by the insurers? Are we so concerned about the fact that you young folks are ready to step into the world of clinical care? So when you go to the ADA site and look at the frequently asked questions, they're asking everybody. In fact, now, and Teresa, you can verify this for me. Just recently in the ADA news, I get the ADA news every day. I read it on my iPhone, my iPad. They're now coming at you folks, the young clinicians, those who've been out of school for 2, 3, 5 years and more, to now go with their Congress and advocate against the bill. Will it be successful? My partners in crime at the Santa Fe group are very concerned about this. We fought for a long time to get the oral benefit into Medicare Part B. Now there are some barriers out there that we need to address. And those barriers include the reimbursement system and the technology system. Teresa, I'll turn it over to you.
Well, thank you. This is a sticky wicket, and I applaud your, it's courageous to take it on. So I think we should always begin with what we do have in common and what the ADA has advocated in positions that I think that are easy enough for most practitioners to get behind. One is that oral health is essential health. That requires duties and responsibilities. And before you accept the benefits of it, you have to realign to the duty and responsibility of it, which includes the primary care responsibility we've had. And I also read the language, and I'll see people push back and resist that. And you'll say, it's about territory. And you'll say, well, it's not your sandbox. We're all landed on the same beach. And our goal is a healthier oral oral health, healthy America. That's what we want. And the health of all of us depends on the health of each of us, and we are committed to this. So we believe in that. We also know that almost all individuals who have some sort of benefit for oral health reimbursement tend to use those benefits appropriately as part of a lifelong commitment to health and to prevention, etc. So those are the things we can rally around. That's what is good. And I will applaud President Clemenson when he talks about essential health and essential care. So those are the things that are right. Now let's get back into just the aging population. So there are more seniors alive today than have ever lived in the history of the planet. That is true. And that by 2030, 20% of the population of the US will be 65 and older, even when you count in the decedent rates for COVID. 20% of the population. The largest single growing group of that are the over 100s, the centennials or the centurions. So we have an aging population. And Becca said earlier when she teed up this discussion about the kinds of pathologies that affect senior populations. Well, it's the usual pathologies. Some of it is related to, there's also a concept of ataxia and other, let me just say, coordination efforts that can occur as a function of time. There's also cognitive dissonance and cognitive impairment that can affect outcomes, even in the best planned and executed treatments. There's also a huge amount of xerostomia that just occurs with age naturally. And then when you add medications like antihypertensives and antidepressants and antihistamines, all of those antis conspire to produce a level of xerostomia that is not compatible with oral health in the traditional way. And we know that when we restore the dentitions of older Americans. And before we just throw our hands up and just let it go, we said, well, what can we do? So this is where the Medicare discussion becomes very nuanced. I think every provider on the planet believes there needs to be a benefit for aging America. I don't think that is I don't think anyone would stand in opposition to that. To Dr. Rouse's point, so what is the sticky wicket? What is the reason that we cannot essentially come to some sort of consensus on this discussion? Well, Dr. Rouse hit it right out of the park. And the ADA has been very, very transparent about their opposition and why. And it has to do with more of how healthcare, dentistry, and medicine is administrated than it does about the delivery of the care. So yes, there's not a universal electronic health record acknowledged. And sadly, that is true. That is true. We do not have that. We report in different systems. And why is that? Because we have done it. So we report in different systems, CDT versus ICD-10 codes, right? Although all of my practice and all of my life, I have coded to ICD-10 codes. So that's really not as big a issue as you might think. It is not insurmountable to think that this can't be done. The other is reimbursement. I mean, at the end of the day, of the 162,000 members of the ADA, I mean, we obviously, healthcare is a calling, but there is an expectation for reimbursement. And reimbursement levels at federal programs are often decided the way they are in TRICARE and at the VA and beyond. So these are discussions about administrations, about electronic health records, about coding, and about reimbursement. They're really not about the need to provide healthcare to seniors. So if we can stay focused on that plane, let's live there and talk about how do we best provide a continuum of comprehensive care to the greatest number in the largest growing segment of our population. That's where we began. And from that, what systems are in place to allow it? Now remember, and I too will, I will not malign the ADA for this approach for advocacy, because I'm a big believer in advocacy. And even if I disagree with what you're advocating for, you still have the right to advocate. The question is how to mobilize the intent. What would young America, now I'm looking here, and with the exception of Dr. Rouse, every one of you were a haploid cell when I graduated from dental school. So the fact that you're taking this topic on, I'm not sure I knew much about Medicaid or Medicare to begin with, but I have learned a great deal. And I know from my 30 plus years in military service what it's like when people do have access to the benefits they so justly deserve. Now at 65, I don't care who's your insurer, you're on Medicare. Part of that benefit, I think, is what many of us consider a useful concept, because we're all going to be Medicare recipients. How we get there, how it's paid for, who's paid for it, and how it's distributed, those are the discussions that take a project like this and automatically build in an interval of opportunity to 2028 to allow us to work that out. I don't think, in fairness, the ADA is opposed to the benefit. What they're opposed is how we are going to get there. And I think they are looking for some sort of way to I don't want to say slow roll. That's not fair. Some sort of way to get all the principals together to discuss how this would happen. Now, look, we've been talking about an electronic record as part of a national database since 2008. So that progress has been glacial outside military service and major health centers, right? That's a glacial process. Record keeping is important, and you don't know how bad your records are until you need to pull a national database. And then you realize, well, we need to have this feed needs to be part of the public health response. So I think all these things are true at the same time. And if it feels a little bewildering to you, then you're in the right place. You are not suffering from a postmodern rationalization of what's normal. This is an opportunity. This opportunity carries risk and responsibilities. How it is executed matters. And no one wants to execute this long sought after goal to see it fail. We want it to succeed. We want it to provide the benefit. And we'd like to do that. I'd like to see it done in my lifetime. So as I get closer to running out of runway, it becomes more of an issue for me. But this will be an issue in your first 10 years, your mastery level of practice and residency training that you will be cut into, you'll pay close attention to, and you'll be part of that solution set with advocacy for the good, for the public good of those affected by decisions made locally and nationally. Over.
Dr. Gonzalez, I really, really, really appreciate you bringing up the viewpoint from the ADA. As students, to be honest, we really didn't understand why we weren't implementing this oral health into Medicare. And we didn't understand that it had administrative blockages and policies. We didn't understand that it has nothing to do with the fact that, of course, these patients at 65, of course, we want them to have oral health. That's not a question. Nobody here is questioning whether or not they deserve oral health care. But more so, it's how do we do it the best way and not have blockages due to dumb policies or things that are out of our control that we could have avoided earlier on. So I really, really appreciate you bringing that to light and helping us understand that it really has nothing to do with whether or not we think they deserve oral health care, because of course we do. It's how do we do it in the best way possible.
It's a great topic, but it's for you to decide. This is about the fellows, the SPEA members on this podcast. Decision-making is so important. Arm yourself with information. Understand the evidence, as Teresa talked about earlier. It's for the common good. It's for the benefit of our patients, our healthcare recipients. And that's how we kind of fall off the wagon and we get off cue when it comes to health equity, because we start making the wrong kinds of decisions. And so this is a good conversation.
Well, and if it's okay, I know we're preparing to conclude, I believe, but I do think you're absolutely right, sir. If you look back at the history of our country over the last 100 years, the college is 101 years old, and you look at things that were flashpoint culturally in our lifetime, the Depression, the World War II, Vietnam, the Gulf Wars, the pandemic, the Civil Rights Movement. And you wonder, why was that ever an issue? Why was that a national focus? And the wisdom of the crowd allowed us to navigate those issues toward the kind of America that I am pleased to hand over to my own grandchildren. And that is one that looks for the better good. I appeal to our better angels in life. And look, maybe we're, as Martin Luther King would so famously say, maybe I won't get there with you. I won't get there. But the fact that you are there to carry the water, because this is advocacy is a full-time lifelong and life-wide goal. I think all of us in the practice of healthcare, I don't care how you practice healthcare or where you practice, I think all of us would be privileged to have people who have access so that the need is responsibly met and that prevention, our biggest worry is converting the disease model into the prevention model. That's what we would concentrate our efforts on. And God knows we've done a lot of that too, professionally. So I know we can get there. I also know that it is sometimes glacial. It is sometimes Brownian movement, and sometimes it's catalyzed by events outside our control. Maybe the pandemic will be such an effect on education and on interprofessionalism. However we get there and whatever those circumstances under which it happens, that when you look back on it, reflect back on where we've come, you can't help but be pleased with the goal and the trajectory we have taken. Now it is your turn as we run this relay, when we hand over this baton and you engage a brand new community of providers dedicated to ethics and professionalism, not because you have to, not because it's a code of accreditation, although it is, but rather because you elect to. That's the provider you were born to be. And that's why you're a doctor. I don't care how you practice medicine. That's why you're a doctor, because you care and you know that the privilege to lay hands on someone came at considerable cost and time and treasure, and now to make good on the promise of an education well done. For me today, it's been my pleasure to be with you. I'm an acquired taste, and I get that, but I appreciate getting the opportunity to be with you. And Becca, I hope you're on the mend here, and I've enjoyed the sidebar conversations with your dog, because let me tell you something, that's the way life is. And to Tim and Anse, and of course to the chief, our president of the American College, I'm lucky to get to serve for SPIA and for the American College. And the reason I left academia to do this job is because the company you keep matters. And the company I keep through SPIA and ACD and other extended community involvement, well, that's where I need to be. And this season of my life, it's where I have to be. And I intend to be here fighting the good fight until the road runs out. So thank you for the invitation.
So let me leave you all with this. I think we did it the last time, Becker. So we talked about health inequity and Medicare. And for those on the podcast, all your SPIA colleagues and our SPIA members, in order to eliminate disparities in health and achieve health equity, we need leaders who care enough, know enough, have the courage to do enough, and who will persevere until the job is done.
Dr. Gonzalez, Dr. Rouse, thank you so much for this conversation. I know me, Tim, Anse, all of us, we have enjoyed this so much and learned so much about health inequities, health inequalities, the Medicare, Medicaid system, how we can best benefit our patients, and how we can be the leaders in our field to advocate for our patients and to bring them the best care that we can. Everyone who joined us today to listen, we really appreciate you joining us. We hope we see you tomorrow. Thanks.